So we're moving into our first body system, reproductive systems. And so I'm going to pick up a little bit of what I covered last time. This is the testis. This is where the seminiferous tubules are. This is where sperm gets stored in something called the epididymis. We would get to that. Here's a cross-section of one of these tubules where you've got spermatogonia on the outside, and then migrating to the inside, you get division, and eventually you get rearrangement of the cells to form sperm. And here's basically the process of meiosis, and meiosis producing 2 cells, and then 4 cells, and then making 4 sperm out of that. So we are going to do the male system first and the female system after that, because the female system is going to lead us into pregnancy. So it kind of needs to be second. So we're doing the reproductive systems. Starting with the male. And starting with these very odd drawings we have of these kind of frolicking people with their insides hanging out. So here's the male system there in the body. The male system starts to develop in the fetus up here. And it migrates out of the body during the fetal period into a sac. That's the scrotum. Here's the testes. There's a reason why if a male gets bopped in the testes that there's a tremendous amount of abdominal pain, because this is where the pain receptors are for that. And also because we've taken a fairly important part of the body, a fairly important function, and put it out where it's kind of vulnerable. We want people to remember, don't let people kick you there. But here's what's going on. We have a set body temperature. And over the course of evolution, because our ancestors didn't, really, really distant ancestors didn't, but there's a certain great efficiency to having a set body temperature, because you can kind of get a temperature that your enzymes all work really well at. Enzymes, if you cool them down or warm them up, they don't work as well as if they all have one, what they call optimum or optimal temperature that they work really well at. And animals that have worked out set body temperatures have also set out a whole bunch of enzymes that work well at that temperature. Well, it turns out one set of enzymes in humans didn't really want to cooperate terribly well. And that's the enzyme involved in sperm production. So if the testes are too warm, sperm production doesn't happen well enough. So probably at some point the testes were kind of close enough to the body wall that evolution doesn't go ways that make sense. Evolution just goes the way it goes. And moving the testes more and more out where they could be cooled by the environment became the evolutionary answer. That isn't what happened in birds. It's not what happened in some mammals. But in most mammals, the testes have during fetal development, migrate out where they can be kept cooler once they start sperm production. Sperm itself are fine at body temperature. Sperm production doesn't work well. It works better down around 94, 93 degrees Fahrenheit. And so these things need to be kept cool. Is if somebody's having trouble making sperm, if their sperm count is low, one of the first things they get asked is what kind of underwear they're wearing. Because if they're wearing underwear that pushes the testes up against the body, which is warm, then they may need to switch to boxers. Is that there's smooth muscle in this sac that actually allows the testes to move up close to the body when it's cool, away from the body when it's warm. But this migration out of the body it goes through slits in the body wall that don't completely close up because the tubes have come out through it, the nerves have come out through it, the blood vessels have come out through it, and all of that is needed to keep this working properly. So there's a weakness, actually two weaknesses in the body wall because there's two tubes and two testes. And those not quite closed up slits in the body wall can open back up if too much pressure in the abdominal cavity is put on them. And that's what causes the types of hernias that men can get, inguinal or femoral, depending on where along the course the opening has happened. And what the doctor does, the old turn your head and cough sort of deal, is the doctor can actually put his finger up in the canal, and when you cough, you increase the pressure in the abdominal cavity, and he can feel whether there's an opening there or not. So it's like, the only reason he wants you to turn your head is because he's right there doing it, and he'd rather you didn't cough on the top of his head. So you turn your head so you're coughing away from him. But he's feeling for the pressure and how much of an opening there is. And if there's more of an opening than there should be, then you have one of those hernias. And if it gets too big and the abdominal pressure goes up, it can actually push loops of your intestine through that opening. And then when the pressure relaxes, the loop is then caught. It's pinched off by the slit reclosing, and it can cut off the blood supply. It obviously can cut off the flow of food through the intestines. That can be a really, really serious thing. A lot of times those hernias not that big, the risk is not that huge, so it's very often an option whether people get that corrected or not. But if you get what's called a strangulated hernia, where the intestines get pinched in there, that is an emergency situation. So here's the testes. Oops. You've got the seminiferous tubules where sperm get made. We just talked about that in the last section. And strings of cells between the tubes, that's an A, make testosterone. Testosterone is not quite as temperature sensitive as the rest of sperm production. So if the testes have not migrated out, it can cause a problem with maturation when you hit puberty. They usually see that as something you do to an infant. You make sure the testes have migrated out into the scrotum. And sometimes they'll go, well, he's going to be sterile without it. But that isn't actually true as long as the testes at some point are moved out. Because you can't make, sperm production is affected. Testosterone production very often is lessened just by being too warm. And one of the big things that testosterone does is it does very much contribute to the development of male features in the fetus. There's certain receptors that react to it. And then when it's produced in large amounts in the testes once you hit puberty, it causes what are called secondary sexual characteristics. Well, actually, sexual characteristics are primary and secondary sexual characteristics. And primary sexual characteristics are characteristics where if they don't work, you can't make babies. So sperm production is a primary sexual characteristic. The ability to have an erection is a primary sexual characteristic. Secondary sexual characteristics are things we associate with adult males that are changes they go through in puberty, but they're not absolutely necessary in order to have babies. They're things like facial hair, broadening of the shoulders as you grow through your teen years, and even facial hair is not in every human subgroup. You don't see this. Same with body hair, armpit hair, and groin hair is pretty reliable across the board. Growth, Here, your voice box grows, the vocal cords get thicker, and so when you strum them, they give you a deeper tone. Your ability to add, excuse me, muscle bulk goes up. To a large extent, your strength does, but we actually add more bulk than we add strength, which is why a wiry little chimpanzee can toss an adult male around, is that they don't add bulk because they're, you know, they go through the trees. You don't want to be any heavier than you absolutely have to, but you need to be strong. Whereas our ancestors were more on the ground display type animals, so bulk was kind of a useful thing for competition for mates. So secondary sexual characteristics are the things like the voice, and as the vocal cords kind of adjust, you have a voice, you know, you get a voice and it isn't always as deep as it's going to be. One other thing about testosterone, since it is associated with muscle building and muscle repair, for a long time it was used therapeutically. If you had an injury where you were bedridden for a while or you were in a cast for a while, they would use testosterone to help you build those muscles back up quickly when you were up and active again. And then people started to go, oh, well, maybe we can take them when we're normal and help build our muscles up. And that's where steroid hormones, testosterone, have become used for athletic issues. Basically, it's mostly illegal, but it's used for bulking up muscles. And what's happened is there's been this arms race between producing a hormone-like substance that will have the muscle building properties, but it won't show up on the tests that they've developed for it. And then they come up with new tests, and they have to rejigger the steroid hormones in order to, again, get one that works that won't show up on the tests. One of the ways they've gotten around that, I don't know if you've noticed, now the Olympics have decided that that when they let an athlete in, if the athlete has competed before, they will go back through their earlier tests with newer tests for the newer versions that they might have been on then. The tests weren't ready for it then. And if they test positive on an old sample in the newer tests, then they're banned. So there have been ways to try to get ahead of the curve for these things. Since the testes have a lot of cell production, then testicular cancer is a real issue. And what happens is you get tumors and you get these nodules, these fairly solid, you know, not solid, but hard lumps. And when there's a high-profile testicular cancer case, then they tell people, you should be checking yourself. But the one thing they almost never tell you is your testes are not alone in there. They have this structure attached to them that you will feel if you go feeling around. It doesn't feel like a lump, but if you don't know what you're feeling for, you're going, oh my God, I have cancer. That is this structure, the epididymis, which is a lot of fun to spell. Epididymis. Epididymis is a place to store sperm. So the sperm that are coming down the seminiferous tubules go into the epididymis, which is full of big tubules, lots of space, and the sperm gets stored there, and they mature there, where by the time they move on, they are potentially ready to fertilize an egg cell. So they have to, you know, cook for a while. And where they're going from the epididymis are the tubes, which are either the sperm ducts, which is what they keep trying to change the name to. The old name is Latin, the vas deferens. And the reason that that is not changing real well when they're trying to change the name is because of a well-known procedure called a vasectomy. So you're making the sperm, In order for the sperm to do their job, they have to get out of the body the right way. They have to be ejaculated. So what if we could block them, keep them from getting out of the body? And so people went, okay, well, they're going out these tubes. It's good, it's a pretty long tube. This is the exit. This is the exit. This is where the tubes feed into the epididymis. This is all accumulating sperm. Here's the exit. Here's the tube. Goes in, goes into the body, goes up and over the bladder, around the back of the bladder. There's a semen gland that attaches to it there. It goes into this thing that looks kind of bony, but it's the prostate gland, where it connects to the back of the urethra coming out of the, this is the big pink thing is the bladder. And from there, there's some semen is added there. It's ejaculated from the body through the penis. So a vasectomy, little incision is made there. The tube is in there fairly loosely. You can grab it and pull out a curve of it, and you can snip it. And then you can seal the two ends so that the sperm that would be going out here can't get past this. It took a while to work out how to get this to be very reliable. Originally, they just snipped it and clipped the ends, and they found that the clips didn't always hold up well, and the two ends didn't always stay separate. They would reconnect in some men. That didn't work. So they got to the point where they would take it out, and they would take a piece out. They would shorten it, and then they would clip the two ends. But in some men, there's a lot of slack here. And even with an inch taken out, sometimes the two ends would reconnect. And so now what they do is that they take it out, they take a piece out, they tie or clip the two ends, but they go into the open ends with the surgical version of a soldering iron, and they sear the two open ends so that they scar over and seal shut. And that's pretty good at keeping it from going and reversing itself. But what'll happen is somebody will go, oh, I changed my mind, I want you to fix it. And the surgeon will go, you know, we went through a lot of trouble to make it not reversible. And so fixing it is not really much of an option. It may turn out that there's still enough looseness in the tube here that you could theoretically, snip it above the scars and below the scars and pull enough tube out to reconnect it. But most of the time that won't work. If you've had a vasectomy, there's sperm in this whole tube. This is another place to store sperm. And for a while, an ejaculation will be clearing out that tube. So you're not immediately not going to have sperm in your ejaculate if you've had a vasectomy. In some people, it can take as much as a month and a half to really clear the sperm out. Then you have to have, a check to see if the sperm are completely gone. This tube is muscular, and you get these muscular contractions that move the sperm along. Liquid gets added in these three tubes, and then the contractions continue through the penis, and that is ejaculation. So the sperm are being mixed with liquid, and the liquid has, there's nutrients in the liquid, there's buffering fluids because the pH of the male system, the female system is a little bit different. You want it not to be a shock to the sperm when they get there. And this little thing used to be called Cowper's gland. It's now called the bulbourethral gland. It is mostly producing lubrication fluid. So during intercourse, it's kind of, getting some fluid out the tip of the penis to help with lubrication. The seminal vesicle and the prostate gland are supplying most of the actual seminal fluid. I want to talk about the prostate gland specifically, though, not because of the fluid that it makes, but because it can cause problems. So there's 3 of them, but I'm just going to talk about the prostate. There's 3 types. There's 2 seminal vesicles. So as men get older, the prostate gland typically gets larger and it can get lumpy. And it can be felt with a fingertip. This is the anus, this is the rectum. A fingertip up the anus can be used to press on the prostate. Let my shadow do it. Press on the prostate and check it to see it, how enlarged it is and whether there's lumps in it, because prostate gland is prone. A lot of cells in there, making more cells. It's another place that's prone to cancer. And this is the old, the thing that you see on all the, in any comedy show has probably done at least one bit on, lean over the table and the doctor puts the glove on with the gel and somebody makes a joke about, you should have bought me dinner first. But what he's doing is he is checking the surface of the prostate. And sometimes there's cancer in there. There's a test you can run for it, but the test is, nobody's quite agreed on whether it's a really reliable test on a certain type of enzyme in the blood. But you can have a biopsy where they punch a little cylinder of tissue out of it and check it for cancerous cells. Here's the thing about prostate cancer. There's 2 basic different types of prostate cancer. There's the nasty kind, which tends to be more common in men in their 40s and 50s. And that is, that's a serious cancer. That can get rapidly out of control and metastasize and kill you. And that needs to be dealt with, very often by removing the prostate gland. Then there's the other type, which is very, very slow acting, not quick to metastasize, and can go 10, 20 years and not really do anything but change the nature of the prostate gland, which sometimes involves closing off the urethra or closing off the vas deferens, which is a problem. But there will be times where, Uncle Andy will come back from the doctor, old Uncle Andy, and he'll go, yeah, the test came back and it's positive for cancer, and we're just gonna, keep an eye on it for a while. And you're gonna go, Uncle Andy, if you've listened to the doctor, he couldn't possibly have told you that. Well, he did. He said to Uncle Andy, well, Uncle Andy, you're 73. This type of cancer usually does not become a problem for 15 or 20 years. That puts you in your 90s. Let's be honest. There's a really good chance something else is going to kill you before this becomes a problem. And we can keep an eye on it. And if it looks like it's turning the wrong way, we can deal with it then. To deal with it now, we have to surgically go in and take this gland off. Try not to mess up these tubes too much and hope that you survive the surgery, which at your age is a risk, and that you're going to have normal urine flow, which you may not have. You may be on a catheter for the rest of your life, and it may have a huge effect on your sex life. And from what you tell me, you still have an active sex life. You may not have such an active sex life after we do this. So what do you want to do? And it's very often in consultation with the doctor that Uncle Andy will go, let's hold off on this. I'll keep coming in and you can check it, every few months. And if it looks like things are bad, then we'll deal with it then. But for now, no, we're not doing anything. And Uncle Andy is making an informed decision. That is definitely not a bad thing to do. Now this blue tissue that we have here, this is the penis. This is an odd type of epithelial tissue that's extremely spongy, and it is called erectile tissue, I think for obvious reasons. And what this is capable of is the blood flow into this, basically this big spongy balloon and this other spongy balloon. The blood flow into it can increase, and the blood flow out can not stop, but reduce quite a bit. And it blows up like a balloon. It literally blows up like a fluid-filled balloon. And that basically is an erection. Not a lot of erectile tissue in the body other than that. The nipples have erectile tissue. In females, the clitoris and some aspects of the vulva have erectile tissue. This is why if you're gonna have gonna be transgender, it is surgically much easier to reduce the erectile tissue and change a male into a female than it is to increase the erectile tissue. There's hormones and stuff you can try that with and turn a female into a male. It's doable, but it's trickier to go one way than it is to go the other way. And of course, if erection doesn't work, that's impotence. Impotence can be psychological. It can be a product of aging of the blood flow, the blood vessels. There's a whole bunch of things connected to it. And of course, there's the famous drugs that help that, like Viagra, that really weren't originally tested for this, but what they were tested for, it looked like they weren't going to get approved. And some smart person went through the side effects and went, oh, that's a really weird side effect. Let's see if we can actually get that side effect to be the effect. And then Viagra was born and became a big moneymaker for the company, so much so that it's got a lot of competitors that other companies have come up with as well. That is the male system. Oh, no, it's not. There is a covering on the end, a foreskin, technically called a prepuce, and that is a sheath. In other mammals, it's a sheath. In a lot of other mammals, the penis is almost retractable, and it retracts into the sheath. If you've ever seen dogs or cats that are aroused, you can get kind of an idea how it works. Well, in humans, for ancient reasons I don't know that anybody understands, there are cultures that ritually will cut it off. And for years it was like, oh, we can do it, the baby doesn't really feel it. The babies seem to disagree with that. And it's become a big issue. It's not medically necessary. It does reduce some chances of some conditions, but it's not medically necessary. Is it child abuse? Is it not child abuse? It's an important cultural aspect for a couple of different major cultures. And so you're gonna find arguments about that. Probably easier to do on an infant than it is to do on an adult. You'd have to ask an adult who had it done. Some conversions involve circumcision. I'm talking about circumcision. So that we started at the beginning of sperm production, worked our way to the exit, and that's the male system.